Very good morning, dear students. I am Dr. Puneet Rijhwani, Professor and Head, Department of Medicine. So, dear students, today we will be talking about obstructive sleep apnea. We all know whenever we think of obstructive sleep apnea, the thing which comes to our mind is snoring. So, today I want to talk about obstructive sleep apnea. It is not just snoring, it is much more than snoring. Now, to introduce, sleep disordered breathing is an umbrella term consisting of disorders that are characterized by abnormal respiratory pattern during sleep. Now, conditions are ranging from snoring at the mild end of the spectrum to obstructive severe sleep apnea at the severe end. OSA is the most common sleep related breathing disorder. It is caused by repetitive collapse of the upper airway during sleep and is characterized by obstructive apneas, hypoapneas and respiratory effort related arousals. It is called as RERAs. Now, something about the epidemiology and the risk factors. The prevalence of OSA is high and on a rising trend due to the increasing rate of obesity in the world. Global prevalence of OSA is nearly 1 billion in the age group of 30 to 69 years, with India standing on the 4th spot in the world. What are the major risk factors? Male sex is the most important risk factor for OSA. An Indian study conducted among middle-aged urban Indians estimated an overall prevalence of OSA to the tune of 9.3%, of which the men were 13.5% and women 5.5%. That means the men or male sex is most important risk factor for obstructive sleep apnea. OSA is 2 to 4 times more common in male, but the risk appears to be similar in the postmenopausal females. Why is it so? It is because of the hormonal changes postmenopausal period and the hormone supplementation which is done in the postmenopausal time. It is protective. Obesity, as well as we all know, obesity is the second major risk factor for development of OSA. Up to 60% of patients with OSA are either overweight or obese. High BMI is another risk factor. A substantial decrease in OSA severity following weight loss has been demonstrated, and longitudinal analysis indicated that a 10% decrease in the weight, 10% increase in weight leads to 6-fold rise in the risk of developing moderate to severe obstructive sleep apnea and a 32% increase in AHI index. Now, age is another important risk factor. The prevalence keeps on increasing from adulthood, but it plateaus after the age of 70 years. Other risk factors are upper airway abnormalities, craniofacial abnormalities have been implicated in increasing the risk of OSA. A study that noted that a majority of Asian men who had severe OSA were non-obese, and differences in the craniofacial anatomy was considered as an important risk factor in this population in comparison to the Western population. So, there is OSA in the Asian men more because of craniofacial abnormalities and not just because of obesity. There are certain genetic factors that produce the OSA phenotype, usually affect the body fat distribution, craniofacial morphology, and relatives of patients with sleep apnea have 2 to 4-fold greater risk of development of obstructive sleep apnea. Other risk factors are smoking, menopause, nasal congestion, ambient air pollution, and a number of comorbid conditions are also associated with higher prevalence of OSA, although whether these are associated with OSA or simply reflects the common risk factors of these conditions is still under evaluation. So these conditions are diabetes, hypertension, congestive heart failure, stroke, atrial fibrillation, endocrine disorders like hypothyroidism, acromegaly, ESRD, gastroesophageal reflux, and many. So this is the pathophysiology of obstructive sleep apnea. Now we can see the oral airway and the nasal airway. In this first part of the slide, both the oral and the nasal airway are patent, so the patient breathes normally. Second is there is partial obstruction of the airway. This is the partial obstruction. Due to this, there is bizarre entry of the air from the mouth. So this turbulence causes snoring. And in the third part of the slide, we can see that there is obstruction both in the oral airway as well as the nasal airway. So there is complete obstruction, and this is the stage when the patient develops obstructive sleep apnea. Now, what happens exactly? There is onset of sleep. Due to onset of sleep, there is loss of muscular compensation, there is decreased pharyngeal muscular activity. All this leads to collapse of the upper airway, and that causes apnea. Due to apnea, patient develops hypoxia and hypercapnia. This all lead to increased ventilatory effort. Patient gets arousal from sleep. The pharyngeal muscle activity is restored. This leads to airway opening, and finally the patient hyperventilates. That causes hypoxia and hypocapnia, and as the patient relaxes, again there is onset of sleep. So this is a cycle which keeps on repeating over the night, and there is impaired sleep of the patient. Now, what are the clinical features? There are certain daytime symptoms, certain nighttime symptoms. What are the daytime symptoms? The patient comes to us, to the doctors, with complaints of early morning headaches, daytime sleepiness. Patient complains that whenever they are free or idle, they go for sleep whenever, even on the chair or in the offices as well. Patients have poor concentrating ability. They are irritable, falling asleep during routine activities. And what are the nighttime symptoms? Patient have loud persistent snoring. This can be seen by the bed partner. There are witnessed pauses in breathing, choking or gasping for air is seen. The sleep is restless, and frequent visits to the washroom. So these are the features with which we can recognize that the patient might have obstructive sleep apnea. Now, physical finding, how to diagnose a patient that the patient might be having sleep apnea. It is very easily diagnosed. Only important thing is a good clinical history, physical examination. There are not many investigations except for polysomnography for the diagnosis. If you suspect, as per the clinical features and just the physical finding, these are large waist and neck circumference, abnormal increased Mallampati score. This is the score that identifies risk for difficult tracheal intubation. This is being normally seen by our anesthetic colleagues. There is the narrowing of the lateral airway wall, enlarged tonsils, retrognathia, high arched hard palate, low lying soft palate, and nasal cavity should be inspected for septal deviation or if there are any polyps in the nasal cavity. Now, how to diagnose sleep apnea? There are certain guidelines which have been laid by American Academy of Sleep Medicine. Diagnostic testing performed in patients with excessive daytime sleepiness and the presence of two or more than two of the following features. These features are habitual loud snoring, witnessed apnea or choking or gasping during sleep, and systemic hypertension. As we know that 50% of our patients of obstructive sleep apnea have hypertension. So these are at higher risk or moderate to severe obstructive sleep apnea. Now the use of HSAT, home sleep apnea testing, also known as out-of-center sleep testing, OCST, or polysomnography, is recommended for the diagnosis of obstructive sleep apnea. And in laboratory polysomnography or sleep testing is the gold standard for the diagnosis and should be performed in cases where home sleep apnea testing is negative or technically inadequate or inconclusive. Now these AASM these guidelines recommend against the use of clinical tools. There are certain questionnaires, there are certain projection algorithms by which we diagnose OSA, but we should not label the patient to be having OSA only by these questionnaires. These are just to help for the diagnosis, but the final say is with polysomnography. Now we'll talk a bit about these questionnaires. And the mnemonic stops. S is for snoring, T is for daytime sleepiness, O is for observe that you stop breathing during sleep, and P is for high blood pressure. Similarly, another questionnaire is the mnemonic goes by the mnemonic BANG. B is for BMI greater than 35, age more than 50 years, neck circumference more than 17 inch, and male gender. Now what is the importance? If the criteria from both the STOP and BANG mnemonics are met, the sensitivity of the patient having an AHI of greater than 5 is 93%, and an AHI of greater than 15 is 83%. So by this questionnaire we can suspect by the clinical features, by this questionnaire in the OPD itself, that the patient might have OSA, and all these patients fulfilling these criteria should be subjected to polysomnography, then only label that the patient is having obstructive sleep apnea. Thank you so much. Thank you.